Hello, everyone. It is my great pleasure to be with you today to present this webinar. My name is Christian Makary. I am an associate professor at the oral surgery department at the St. Joseph University of Beirut in Lebanon. And I'm presenting today this webinar through the ICOI platform. ICOI, that is one of the most recognized association in the world. And I had the privilege since more than 20 years to be associated to this association. I'm not only a member, not only a diplomat, I'm also an ambassador for ICOI. I'm the vice president for Lebanon, and I am a member of the Advanced Credentialing Committee. So thank you, ICOI, for putting us all together and for pushing implant education all around the world. Today, I will be talking about immediate implant placement in the aesthetic zone and more specifically into extraction sockets. And we will try throughout this lecture to put the guidelines for a successful aesthetic result in order to be able to achieve in a predictable way our aesthetic outcome whenever we are doing implants in the anterior region. So when we talk about the aesthetic zone, we have to judge our implant restoration. We have to judge our implant restoration by judging our gingiva, the contrast between the pink aesthetic and the white aesthetic. We have to be able to see the harmony in the colors of the crowns. We have to be able to see if we have a papilla that is filling the space between the lateral and both the canine and the central incisor. In this case, taking into consideration that this implant in the middle is an implant supported crown. And then it's also important to see in a tridimensionally if we have enough convexity on the buccal part of the gingiva, which is the sign of a healthy, soft, and hard tissue around this implant restoration. And of course, if we have or we don't have these aesthetic criteria, if we succeeded or we failed in this implant successfully, it is due to the fact that we have an implant that was placed in either the correct or the wrong position. And based on the position of this implant, based on the size, the type, the geometry, the surgical technique, we can either end up having a nice aesthetic result or a bad aesthetic result. And moreover, it is very important also to be able to respect all of these criteria in order to see this aesthetic result over the long term. And if we want to have this type of gingiva, whenever we want to place our final restorations, we need to be able to create this gum by respecting biology, by respecting implant placement, in order to be able to have this type of restoration the day of this type of aesthetic outcome the day that we will place our final restoration. It is very important to be able to respect a lot of criteria that we will be discussing today. Otherwise, if we don't respect these criteria, unfortunately, we might end up having this kind of failures. The problem in this case is that our implant is, unfortunately, I would say, osseointegrated. And today, the challenge in implantology is not anymore to be able to have an osseointegrated implant. The challenge is to be able to have an osseointegrated implant in the right position, in the right place, being able to help us achieve an aesthetic result. And this is only by following the biological rules, the surgical rules, the prosthetic biomechanic rules in order to succeed our restorations. And maybe in this particular case, this particular failure, one of the most difficult things in order to correct this failure is the fact that this implant is osseointegrated, because then we need to remove it, and it's not always easy to remove an osseointegrated implant. Sometimes we need to remove it with the bone and create more bone suffering, more bone loss around this implant and soft tissue loss, and then we have to create everything from scratch. So in order to avoid having this type of failure, we need to be always aware of the availability of bone and soft tissue. We need to choose proper implant geometry. We need to place our implant in an ideal positioning, and we need of course, to be able to understand biological changes that will occur around implants. And in order to have a successful implant case, we have to detect our risk factors. And we know that we have low risk, medium risk, and high risk. And when we are placing implant in the aesthetic zone, it is very important to be able to detect throughout our initial consultation this notion of risk in order to avoid placing implant with a high risk, because this is when, or medium risk even, because when we are compromising our aesthetic results. So from the initial consultation, going to the clinical examination, the radiographic assessment, the wax up, planning, surgical guide, implant placement, follow up, and finally the final prosthetic restoration, we need to be aware of all of these risk that might be present in our case, in our restoration, or in our surgical procedure. And we need to understand that an implant, as you can see in this picture, is not at all biologically equal to a natural tooth. And when we understand that implants are totally different biologically, we can understand what happens after we place our implant. Like, for instance, you can see that a tooth has a ligament, a periodontal ligament, while an implant is ankylosed inside the bone. We see that the contact between the implant abutment and crown and the bone is not always the same as a tooth, because we have the attached and the biological widths that is here to protect our bone from our crown whenever we are on a natural tooth. But also we have to know that if we need to succeed our implant restoration, we should understand, for instance, that we also have the concept of biological widths around implant. And this is a concept that has been evolved through the years. When it was first published in the 1997, and we understand now that one implant that was, after an implant is placed, osseointegrated, once we connect the abutment, we connect our crown, and we have an implant infection, we will end up having what you can see here. We will have marginal bone loss around the implant, and this is mainly due to the fact that we have sometimes a micro gap between the implant and the abutment, but also due to the fact that we have a biological width. And today, we don't have the time to develop all implant geometries, but we have very new geometries. We have the platform switching concept, we have the conical connection concept that are playing on these micro gap interface, on these biological widths, in order to reduce marginal bone loss around implant, in order to be able to have a more stable hard and soft tissue around implants after implant placement. Because we know, and this has been historically proven over the years, that after we place an implant, we always end up having crestal bone loss around this implant, that in some publication could be described as being 1.5 to 2 millimeters. And of course, these are not the standards of the 2025. These were the standards of the 80s and the 90s. This is why I said that today we have new trends, because we have new implant geometries. But whatever it is, we always need to respect the same. We need to respect the positioning of the implant, the distance between two implants, the distance between one implant and a natural tooth. And you can understand that in order to be able to preserve this soft tissue papilla, it is very important to preserve the bony papilla, and implant placement will induce, if misplaced, a resorption of this bony papilla that also will induce a resorption of the soft tissue papilla. Also, when we place two implants close one to the other, you can see that these implants sometimes will induce also a bone loss. This is why it was described by Tarno and co-workers that the minimum distance between two adjacent implants should be of 3 millimeters. And this is very important to respect these distances, which is 1.5 to 2 millimeters between an implant and a natural tooth, 3 millimeters at least between two implants, in order to avoid having aesthetic failure, especially in the anterior zone. And this bone that is here on the buccal, this bone that is here on the mesial, this bone that is here on the distal, whenever we want to place an implant, is the guarantee that our implant will not be placed with a compromised bony envelope. It will be placed with a bony envelope that is protecting it, and by protecting the bony envelope, we will protect the soft tissue envelope, and we will protect the long-term aesthetic of our restoration. And if you look at this case that I made more than 30 years ago, this was at the beginning of my implantology career, and when I look at this smiley patient, everything looks normal, but when we look at the tooth, you can see that here we have a loss of the papilla. And what can be the cause of the loss of the papilla? Why did I lose my papilla on the mesial and I did not lose my papilla on the distal? And the answer lies inside the radiographic image that I took to this implant. And you see that I lost my bony papilla on the mesial because I placed my implant in the wrong position. My implant was too close to the natural tooth. But what if I take my implant more to the distal? Then I will be too close to the natural tooth from the distal side, and I will lose the papilla also from the distal. This is why the problem maybe in this case was the wrong choice of implant geometry. The problem was the bad positioning, and the problem also was a bad understanding of the biology around dental implants. So in this case, maybe I would have seen if placing an implant with a smaller diameter would have given me the chance to have 1.5 millimeter from each side in order to protect the hard tissue papilla and in the same time protect the soft tissue papilla. Or if this was not possible, maybe I would have had to do an orthodontic treatment, for instance, to have the proper distance mesiodistally to place my implant, or avoid placing an implant if I don't have all the criteria that I need. And if we don't have bone, we can recreate bone. This is something that can be done. It's not the topic of my lecture today, but you can see that we can recreate bone by autogenous bone, by doing some guided bone regeneration. You can see here, for instance, we have a severe vertical bone loss, and I would never place my implant at the level of the bone in this case, because if I do, I will end up having another aesthetic failure. So we need to recreate the bone. We need to recreate the bone by doing bone grafting techniques. In this case, it was a non-resorbable membrane with an allograft. I let it heal, and you see that the defect was like this, and the bone gain was at same as our expectations, because we could recreate the bone that we had, and in this case we placed our implant, and now you see the ideal implant placement mesially and distally distant from the tooth, and you see how much bone I have on the buccal. I have more than 2 millimeter of bone, or 3 millimeter even in this case, of bone on the buccal, in order to protect my soft tissue and protect my future implant restoration. Then we temporize, we lead, we guide the tissues, and we end up with the final results. This is with the abutment, and this is with the final result, and the implant that was placed in a restored bone in the ideal position, following the ideal or the specific prosthetic requirements in order to be able to preserve the bone, the papilla, and the long-term aesthetic results. In this case, for instance, we did not have bone. We recreated bone. We start by grafting. We can sometimes place implants and grafting in the same during the same session. Sometimes it's much wiser, probably in the aesthetic zone, to grow the bone and then grow the implant. And this is the case after growing our implant. You can see here that we have a tissue loss. But is this tissue loss related to bone or related to soft tissue? Only radiographs will tell us. This is why it's very important to have a CBCT image, a 3D radiographic image that will show us the amount of bone that we have in this position, because we need to place 2 implants. And you can see that in this case, I have enough length and enough width to place my implant because my graft did succeed. So now I need to planify my case. It's very important then to take an intraoral scanner. And I know that today, digital planning has become one of the most important tools that we have between our hands in order to succeed our implant restorations. So once we have the radiographic file, that is a DICOM file, and we have the intraoral scanner file, that is an STL file, all we need is a software in order to superimpose and do our planning. There are a lot of softwares on the market that you can use. Some of them are free, some of them are paid. I used this software in order to planify my case. So what we start doing is doing a wax up for my virtual teeth, and based on this WhatsApp, I will place my implants respecting the criteria that I was talking about, which means that I need to have a proper distance between the implant and the natural teeth, and a proper distancing between the implant and the two implants together. And I need to have enough bone on the buccal and enough bone on the mesial and distal in order to be able to secure my restoration. Then I prepare my surgical guide. I prepare my temporary crowns, because it's always very important, the aesthetic zone, to be able to temporize immediately, not only for the aesthetic of the patient, but also to help our tissue heal over these temporary crowns. And I use my guides in order to place my implants through this surgical guide. I need a guided implant guided surgery kit. So in this case, some would think that it's better to do flapless implant placement, because we did not because everything is guided in advance. But I would not recommend it, because we need the tissues. Tissues are very important, and we need thick tissue. And if you remember, in this particular case, we did not have enough soft tissue at the beginning. So we don't need to open a big flap as I would have if I was doing it freehand. I would just open enough to expose the bone on the crestal aspect, and I will start doing my drilling. So the drilling will go in a drilling sequence, which means that I will go from the shortest drill till the longest drill that I want to use, and then I will start going in a sequence of bigger diameter. So you can see here that I am using the same diameter with different lengths. And if I use from the beginning my long drill, I will end up changing the axial position of my implant. This is why it's very important to respect it and go incrementally with our drills. So once we reach our final length, in this case it was 13 millimeter, we will start working on the opening of the diameter of the implant. This is the 2.8 millimeter drill. And then we will use, in this case, the final drill that was a 3.3 millimeter drill in order to be able to place two 4 millimeter implants in the position of central incisor and lateral incisor. Always remember, and it's in every surgical kit that you use, guided surgery kit, you will have the possibility to control two things. The first thing that you need to control is how deep your implant would be, and this is the line that you can see here. And the second thing is being able to control the direction of your connection, which means the positioning of the hex, because you want to place your abutments later on. And this is why it's very important when you do this type of surgery to get back to the surgical manual and be able to control how much you want to sink your implant and the hex positioning on your implant connection in order to be able to reposition exactly the prosthetic tooth. So in this case, if I wanted to do an immediate temporization, and this is what I decided to do, I need to have enough implant stability, implant insertion torque, and this is where the geometry will play a major role. And this is not part of our lecture today, but it's a very important topic. So now, because I had a loss of soft tissue, but I had enough hard tissue, I did graft only soft tissue, and this was a connective tissue graft in order to recreate the buccal contour and in order to thicken our soft tissue to recreate the proper aesthetics. So now it's an easy procedure, taking a connective graft from the palatal side and suturing this connective graft on the buccal of this flap. And now I will place my temporary crowns, and I will suture. As you can see here, I place my crowns that were pre-prepared at the lab based on the planning that I did, and the implant that were placed respecting this planning. And now I will let the tissues heal around these two temporary crowns that were prepared and placed. So this is at the end of the surgery. This is the two implants, and you can see the position of my implant where I respected the distancing between the implant and the distal part of the canine, and mesially with the central incisor, and the distance between the two implants. And you can see how at the end of the implant healing, we moved from this situation when I had a concave profile to this situation where now I have a convex profile, and where I could help my tissue to heal around my implants. And now my implants are ready to receive the final restoration, as you can see here, in order to restore my aesthetic results. But this was mainly in a situation where we did not need to extract the tooth and place an implant, which means that the bone that we had in this situation was a healed bone, a bone that was more of a static bone. And when we placed our implant, when we place our implant in a bone that is already healed, we know that we will not have a lot of remodeling of the bone because of a healing process. We might have some remodeling around the implant, but not a remodeling for the bone per se. Whereas when we place our implant in an extraction socket, this is where we are dealing with a situation where the bone is moving, is resolving, is changing. So we are not in a static resolution, in a static state. So if you want to go from this situation when we extracted our tooth to this situation the day of placing our abutment, and this situation the day of placing our final crown, we need to respect a lot of criteria, and we need mainly to understand the biology of the bone, because we know now, and this is something that was described over and over, that once we have a tooth extraction, we have a bone loss that will occur during the months following this tooth extraction. And you can see this is at 6 weeks, you see how much I lost vertically from my soft tissue, and this means that I also lost, of course, the hard tissue. And this is also at 6 weeks only. We're not measuring yet at 6 months what happened. You see that I lost a lot of bone because this socket was left alone. So the question today is, are we going to leave our sockets alone? Are we going to go from this situation, from instance here, where I had a premolar, and after extracting the premolar, you can see how much bone loss I have. I moved from a situation where my bone was almost here to a situation where my bone was resolved, and I moved to a situation where this is the yellow line is the old soft tissue, and the red line is the new soft tissue contour. So you can take only in 4 months how much I lost bone in this case. And we did a study that we are now publishing that showed that we can lose only in 4 months up to 30% of the bone and the soft tissue. And there are some studies in the literature that show that at 6 months we can go all the way up to 50% of the bone. So are we going to wait and lose the bone, as you can see here in these two impressions? Of course not. So what are the solutions? The easiest solution, if you want to extract a tooth, is to do what we call a rich preservation, which means that we will graft this socket, and by grafting this socket, as you can see here in this case, you can leave the soft tissue contour and the hard tissue contour as being the same, almost the same, because we did not allow our socket to heal. And this is what we usually do whenever we want to extract a tooth, and we have in mind placing an implant. Like in this case, I do always atraumatic extractions, and this is very important because I don't want to do further injury on the bone when I remove my tooth. I need to keep the bone as much as possible. I use ultrasonic surgery in order to do atraumatic extraction. There are other techniques in the literature, but this is what I use. Once I removed my tooth, I clean, debride, I place my graft, then I take a soft tissue punch, as you can see here, and I place over my socket, and this soft tissue punch will heal to grow more gingiva and will help me protect my graft during the first weeks after placing it. And we end up with a situation like this, where we could preserve our buccal and contour from a hard tissue and a soft tissue point of view. And now I can place my implant, and you can see that I have enough bone to place my implant, and I have enough bone buccally to this implant in order to preserve it. So 6 months after my graft, I placed my implant. I placed my healing abutment in order to let the tissues heal. And then 9 months later, I had my final restoration. So following these steps, we can always get very acceptable results. The only problem is that 9 months from extraction to final restoration is not always acceptable by the patient. Today, our patients want to have immediate results. Today, it is the right of our patients to be able to have the state-of-the-art protocols. And the state-of-the-art protocols are not slow protocols. Today, we can either go with a slow protocol, which is delayed implant placement with grafting, rich preservation, placing the implant, second-stage surgery, waiting for healing of the soft tissue, and then placing our final crown. Or we can go with more accelerated implant protocols that are, in this case, placing an implant immediately after extraction, with an immediate temporary tooth, grafting immediately in the same time the gap between the implant and the buccal bone in order to preserve the soft tissue. And this is the technique that is today considered as the technique of choice in implantology. And we will discuss this technique during the time remaining of this webinar. So what are the guidelines for immediate implant placement? In order to be able to perform an immediate implant placement, we need to be able to perform an atraumatic extraction, because as we said, we don't want to lead to a more injuries to the bone, because this bone is needed to place the implant. We need enough bone to stabilize our implant. We need an implant geometry that can give us a good primary stability, because we need to temporize immediately. And of course, we need to be able to place our implant ideally. And this is very important to use today, guided surgery and softwares. And what matters more is being to have a proper aesthetic result and long-term stability of hard and soft tissue envelope. So you can see here that I placed an implant freehand. I was able to stabilize my implant in the right position, take an impression, and send it to the lab, and then let the lab fabricate 2 temporaries that were placed to the for my patient the second day. Today, protocols evolve, and as I showed you in the case of the 2 incisor, today we have digital dentistry that emerged, and today all of these steps can be used digitally, guided surgery, doing intraoral scanners, using digital technology to do the impression and to do the temporaries and to follow up our cases. So if we go back to this case, did we have the choice? Was it mandatory for us to extract and wait and lose all of the bone? Of course not. I had the choice, because if I follow the guidelines, can I, in this case, remove this tooth atraumatically? Yes, I can. If I follow the protocol, if I use a very specific technique, I can remove this tooth without breaking the buccal bone that is very thin here on the buccal. Do I have enough bone to stabilize my implant? It seems like I have, because this is the apex, and look how much bone I have on the palatal. Can I use the proper geometry? Of course I can. Can I place my implant in the ideal position? Of course I can do this by following the anatomy or by using guided surgery. And once I place my implant, as you can see here, instead of placing an implant that is outside the bone, if I wait, I can place an implant in this basal bone, stabilize my bone, and then in order to have a long-term hard and soft tissue envelope, I need to graft the gap that you can see here between the implant and the buccal bone. And this graft is always grafted unless you are doing a root membrane technique that I will not be able to develop during this webinar, because we need more time to do it. I will only talk about technique where we graft the gap. And then it is very important now, by grafting the gap, we preserve the bone, but also in order to preserve the soft tissue and guide the soft tissue healing, to be able to place a temporary crown, as you can see here, that will guide the soft tissue healing. And if we look at the first case, so this is a case where I had to remove a premolar and place an implant immediately. So in this case, in order to be able to decide if I want to place my implant immediately or I want to do a delayed implant placement, the decision depends on the fact that if I can remove and place an implant immediately, of course, today the standard of care would be to remove and place an implant immediately. So we need to planify our case, and this is very important. By planifying our case, we need to be able to have a CBCT that will show us the hard tissues, the bone, and in a 3D manner where we can do all the measurements, but also we need to have an STL file, which is the intraoral scanner, and we need a software, as I said, to superimpose these images, and this will let us fabricate a surgical guide, a temporary tooth that will be placed immediately after placing the implant. So the case will always, as we said, start with atraumatic extraction. If we don't extract this tooth in an atraumatic way, we might end up losing the bone that we have here on the buccal. And this is something that we don't need to happen. This is why we follow a technique where we use ultrasonic insert in order to do what I call a periotomy around the tooth, which means that with this insert, I am penetrating inside the periodontal ligament in order to make this tooth easier to extract. And if we find that this tooth is not moving, we might end up cutting it also and removing it in pieces. What matters is being able to preserve the bone that you can see on the buccal of this tooth, because this bone is very important when I place my implant, mainly that it will hold the graft that I will put in the gap, and it will preserve later on the hard tissue envelope and with it the soft tissue envelope. Number two, we need to debride our socket. We debride our socket in order to remove any granulation tissues, because we don't need to have granulation tissues that might compromise the implant placement. Then we place our surgical guide. As I said, this surgical guide was prepared prior to the surgery based on the digital study that I performed on my software. And I start going in an incremental way, going in different lengths with the same diameter, because I don't want to compromise the direction of my implant. And once I reach the different diameter in lengths, in this case it was 13 millimeter, I start going in diameter, progressive diameter. And this is the 2.8, 3.2. And now this is my final diameter. In this case, I'm placing an implant that is 4.1 millimeter. You can take always a radiograph to make sure that you are in the correct position. And now we are placing our implant. So this is the implant. And by placing this implant inside the bone, my goal is to be able to have a proper primary stability. And this is when the geometry of the implant will play a major role. Some implants can provide a better primary stability, a better insertion torque, a better osseointegration, because they have enhanced surfaces. And this is very important whenever we want to apply accelerated protocol or immediate temporization or immediate loading, for instance. In this webinar, we will just focus on immediate extraction sites because we don't have the time to develop everything related to immediate implant placement. And you can see that now by measuring the torque of my implant, I have an insertion torque of my implant that is very high. It's around 60 Newton centimeter, and the threshold that I need to have usually is 30 Newton centimeter. Then comes the part when I need to graft the buccal gap that is between my implant and the buccal bone. By grafting this gap, I will be able to preserve, and we will see at the end by showing some of our clinical and radiographic results, to be able to preserve a buccal bone envelope, because this buccal bone envelope will help me. As you can see here, you see that now I have enough bone on the buccal that I grafted. And by preserving this bone, I can preserve the soft tissue envelope. And this is the temporary crown that was already prepared in advance. And you see that if your planning was done properly, this crown will go very smoothly in its position. So no need to take an impression and send to the lab. The patient will go immediately with the crown. Now, all we need to do, and this is very important, is to be able to control the prosthetic load on these tooth. Because this tooth is a temporary tooth on an implant that is not yet osseointegrated. It's very important, first of all, to remove any occlusion force, and this is something that we will do easily, but also we need to be able to remove any laterality on this crown, because as you can see, this crown was a little bit long, because sometimes the lab will plan the crown in an aesthetic way, but we have to keep the aesthetic, but also make it functional and make it safe for the tooth. And you see that now in laterality, I have no more touching of my tooth. I have no occlusal force on this tooth, and this will not at all, in this case, then compromise my implant when the patient is grinding, for instance, or during the sleep. But of course, the patient can easily eat on this tooth and chew on this tooth without any problem. And you see, after 4 months of healing, when I remove my crown, the tissue and the quality of the tissue that I have, and this tissue that is ready to receive the final crown. Usually, I wait until I place my final crown 6 months, not because I'm waiting for osseointegration, of course not, but because I need the soft and hard tissue to mature to the max at the extraction socket. And I'll show you later on that even 1 year after extraction and implant placement, we can still have some resorption of the bone and resorption, if not resorption, I would say remodeling of the bone and remodeling of the soft tissue envelope. But at 6 months, it is very safe to place our final implant, and you see that we could preserve the papillas, we could preserve the buccal contour, and we could preserve the aesthetic throughout the whole process for this patient, from day 1, day of extraction, until we place the final crown. And if you look radiographically, you see the stability of the bone over this implant. And what is very important is to be able that we could recreate this bone on the buccal of this implant, because this buccal bony shelf will hold the soft tissue and will give a long-term aesthetic result. So this is another case where I want to replace an aesthetic. In the aesthetic area, that is a more tricky area, a incisor crown. And you see that in this case, I need to remove this incisor. And if we try to analyze a little bit the situation, we have a situation in the aesthetic area where I need to be able to place an implant in this socket. Can I remove this tooth atraumatically? As we said, yes, by using the proper technique. Can I place an implant? Do I have enough bone? It seems that I have some bone on the palatal side of this implant, so I can place an implant that is long enough to get anchorage above the apex of the tooth, in order to have enough anchorage also to be able to temporize immediately this implant. We need to graft the area on the buccal, because it's very important, specifically in the aesthetic zone, to be able to preserve the hard and soft tissue envelope. So we do a planning, and this is the planning of this tooth, the central incisor. Based on this planning, I place my implant. As you can see here, if we try to analyze our implant placement, our implant is placed usually on the buccal aspect of the socket, because the more we go on the palatal aspect of the socket, because the more we go palatally, more we have space on the buccal to graft. If I place my implant in the middle of the socket, I will end up having my implant very close to the buccal bone, and I will not be able to graft the area buccally to the implant. and I will not be able to graft the gap, which means that I will have a resorption of the bone later on that can compromise my aesthetic result. This is why it is very important to be able to do the ideal implant positioning and choose the ideal implant geometry, the ideal implant length in order to place our implant in the more specific way and preserve aesthetics in the same time. So now we are doing our tooth extraction, and you can see, as I told you, I always like you to use ultrasonic instruments in order to do a periotomy in this case, and it will enormously facilitate my extraction, because at the end of the day, if I extract these tooth and I break or I lose my buccal plate, my situation will be compromised and I might have to do a ridge preservation instead of doing an immediate implant placement. So it is very important to be able to remove the tooth atraumatically, as you can see here. By removing the tooth atraumatically, I am able to preserve the buccal bone that is very important, because this buccal bone will hold my graft, even though it will resorb on the long term, but it will hold my graft. It will play, this is the buccal bone, the role of a membrane. So ideally, I will place my implant here on the buccal, and I will graft the area between the buccal bone and the implant. Again, of course, we can do it freehand, but if we have the luxury to do it guided, it's much easier to do it guided, because in this case, you need to be doing a perfect positioning, and you have to be a perfect position from a surgical point of view in order to be able to avoid having a loss of the bone on the mesial and the distal, but also we need a perfect position from a prosthetic point of view, because as we said, we need to place our crown and we need to place an aesthetic crown. So by taking a radiograph, I always do it in order to double check if I did a proper planning of my restoration. And now, as we said, we go incrementally in the length of the drill in order to avoid changing the direction, and then we do the preparation of the diameter. And you see that I did my preparation as planned on the palatal. I placed my implant. In this case, it was a nanny-ridge implant from Makary. These implants have a very good geometry that can allow them to give us very nice stability, because as I said, we always need to be able to have stability that can be around 30 Newton centimeter before we do immediate temporization. And I want here to stress on the positioning of the implant. So as I said in the beginning, when we place an implant guided, we need to be able to control how deep we place it, and this is the line that control how deep we place our implant, and we want to be able to orient the connection. This is why you see the green part of my implant holder will always be facing the buccal opening on the guide. So these rules are very important. Each implant system and each surgical guided surgical kit would have its own recipe, but they all serve the same purpose, that is being able to sink the implant ideally and to place the implant, orient the implant the way we want. So once we place our implant, we're sure now that we have enough stability for our implant. Now comes the time to graft this gap that you can see here. So the gap that is here on the buccal should be grafted, because we now need to have a breakdown or a resorption of the buccal contour. So we start placing our graft very gently between the implant and the buccal plate on the inside the gap. In this case, it was a bovine graft. Bovine graft have the advantage of being very slowly resorbed, so they will give time for bone to recreate, and they will keep the contour, and this is what is needed from this graft. It's very important not to overgraft, because if you overgraft and you place more implant above the shoulder of the implant, you might end up having this graft, as you can see here, this one beautiful graft. You don't need this graft to come to the soft tissue department, because it might be infected. And now I place my implant, and you see that my crown, my temporary crown, was immediately placed as planned, as prepared. I can retouch the occlusal parafunction. I make sure that I don't have any laterality or propulsion movement on the crown, and then I let it heal. And you see, this is the healing at 6 months. As I said, for me, it's important to let it heal until 6 months. You see the buccal contour that is almost the same, but you can see here the bone that I have buccally, and in this case also buccally. Also, this is a very tricky socket because it's more of a narrower socket. And this is the final contour. My final prosthetic restoration, you see that I could preserve the papilla on the mesial, papilla on the distal. I have a harmonious contour on the buccal that is similar to the contour of the adjacent tooth. And when we look from an occlusal point of view, you see that I have a convexity buccally, and I did not, which means that I did not lose the bone that was created here, and this is very important. And when we look radiographically, we confirm what I'm telling you. You see that I have enough bone to protect my implant on the buccal. In this case, I have almost 1.5 millimeter of bone. Ideally, if I can have 2 millimeter, it's better. But in this case, I had enough bone to stabilize. And this is at 1 year. So you can see the stability of this restoration. And you see here the contours at 0, 6 months, at 12 months that I will show you. This is part, as I said, of the study that we did in order to be able to control what happens after we place our implant, because it's not only about showing you what I can do and if I can achieve aesthetics, because sometimes you can achieve aesthetic in one case, but the idea is to be able to achieve aesthetics in every case by following the scientific and clinical guideline. So what we need to do after we offer or propose a technique is to be able to assess this technique clinically and radiographically, like in this case, and tell you that this technique worked because we did this kind of study and this is our result. So what we did in this case is we did a case series of implant place into extraction sockets following the same protocol that I showed you, which means guided surgery, implant placement on the palatal side, grafting the gap, immediate temporization to guide the soft tissue healing, and we did a fine crown at 6 months, and we did a follow-up at 6 and 12 months where we superimposed the images and we measured the remodeling of the hard and soft tissue envelope. And if you look at the hard tissue remodeling, you see that we had a mean value that was at 12 months of 2.65. And if you look at a series, and this is a first case series, now we are preparing the publication that you will soon find in the journals. And this study was also partly funded by IDREF, which is the Implant Dentistry Research and Education Foundation that is part of the ICOI. And this is to stress on the importance of the ICOI as a structure that also not only support education but also support research, and it's an opportunity to thank ICOI for supporting our research at the university. And if we look at the soft tissue contour, also you can see that the soft tissue contour went from a retraction of 10% of the contour at 12 months, which is not something huge, which means that we have stability, because this is not something that you can see on the with your eyes, that cannot be clinically obvious. And if we compare this 10% with the 30% at 4 months, which is equivalent of 7%, and the 50% at 12 months, you see that we moved from 50% of remodeling of the contour to 10%. And this is very good because we could, in this way, preserve and achieve a better aesthetic result. So at the end, what are the guidelines that we can today follow in order to do immediate placement of implant in the aesthetic zone? The first thing is being able to assess the situation, of course, and this is why we need to do our proper radiographic evaluation. We need to be able to do an atraumatic extraction. It's very important, because whenever we do a traumatic extraction, when we do a injury or we lose the bone on site, then our surgery is compromised. We need to be able to achieve primary stability. And this is also very important to choose the proper implant geometry. some geometries can give you better stability than others. The implant that I use in these cases were implant that could give me a very good implant geometry because they were designed in a way that I can achieve good geometry, good stability, and help me do immediate or temporization or immediate loading. We need to be able to do ideal implant positioning, and this is the importance of guided surgery. And this is why today we rely on guided surgery in these cases, because we want to place our implant in the ideal position that is ideally prosthetically driven position, and ideally towards the bone, and ideally in order to be able to graft on the buccal. We need to do immediate temporization because we need to guide the soft tissue and we need to give our patient aesthetic. And lastly, it is very important to be able, when we place implant in the aesthetic zone and more specifically in the extraction socket, to have a long-term stability of the hard and soft tissue envelope. And when we respect the guidelines, when we respect the rules, when we do everything as planned, yes, we can have a long-term stability of the hard and soft tissue envelope, which can be translated as having a better aesthetic. And this is why I always tell you, the goal today is not to be able to have osseointegration. The goal today, because we know that osseointegration will happen, the goal today is to be able to achieve aesthetics and to be able to have an implant placed in the ideal place, an implant placed with taking into consideration all of the criteria that we talked about during this webinar. And this is how we can achieve aesthetic, not only in one case, but in every case that you perform. So thank you everyone for your attention. I hope that this webinar was gave you a good insight on the aesthetic implant placement in the extraction sockets, on following aesthetic guidelines. This is my LinkedIn. We can connect. You have also my email if you need to contact me. So thank you, ICOI, for giving me this opportunity, and I hope that we can all meet in person in a future ICOI event.